All right. I don't know why there's an echo, but I'm gonna try. So thank you everyone for joining us for Head and Neck Live. Today is August 3rd. Hope everyone's enjoying the nice Cleveland summer. So just a quick reminder, you can claim the CME with the code in the invite from today. Okay. So this morning we have a special speaker joining us from the Department of Dermatology here, Dr. Shilpi Khetarpal. She'll be speaking to us this morning. So she's an associate professor in the dermatology at the Cleveland Clinic, and she actually completed her residency in dermatology here. And then she did a Mohs micrographics surgery fellowship, as well as in lasers and cosmetic surgery at Skincare Physicians in Massachusetts. So now she's back as one of our experts, and her special interest is in treating surgical scars or scars in general in a non-invasive way. So today she'll be giving us a talk on the treatment of scars. So thank you for joining us, Dr. Khetarpal.
Great. Thank you so much for that introduction, and thank you for having me. So today I'm going to be discussing just a little bit about scars. I run our laser section on A61, so I do a lot of minimally invasive, non-invasive procedures. So hopefully you'll find this, interesting and useful and relevant to your practice. So just a little bit of background, what is a scar? So a scar is a reaction to dermal injury characterized by local fibroblast proliferation, and we get the production of new collagen and extracellular matrix substance. It is the final result of wound healing. It's characterized also by angiogenesis, and that clinically we see as like erythema, telangiectasias, or redness and edema of the scar. And why do we care about scars? They can have, not only a functional impact, but also emotional difficulties that can affect one's quality of life. So there's different ways to characterize a scar. I like to think of this as by thickness. So, we have keloidal scars, which are thickened beyond your area of injury. Hypertrophic are just thickened within the scar line, and then atrophic are depressed. They do vary based on body location and color. There's a lot of different considerations when you're thinking about a treatment plan and how to treat it. We want to look at texture, tension, erythema, obviously the mechanism, time of injury, and all of that before coming up with a plan. So other considerations, the time and mechanism of injury, comorbid conditions, do they have any symptoms? Is it itching? Is it burning? Do they have a contracture? Functional limitations, psychological factors, and what they've tried now and in the past. Of note, things like burn scars tend to have like the deepest injury. So, otherwise surgical scars are relatively well controlled and easier to treat. So other things we look at, patient factors, if it's a child, if it's an adult, is this going to be done while they're awake or just local or some conscious sedation? Obviously Fitzpatrick skin type, our skin types 1 and 2 are much easier to treat than our skin of color patients, age, pain tolerance, symptom relief, and then obviously downtime of the procedure. So, there is a new way of thinking about scars. Instead of erasing them, like, well, let's cut it out and put a new one there. Our goal is to improve their appearance, to rehabilitate the tissue instead of replacing it. And we want to revitalize and restore damaged skin. Ideally, we use a combination approach for patients' treatment plans. So it's usually a combination of injections, topicals, and laser treatments. And many times we'll use more than one laser to give them the best result. So I'm just briefly going to talk about some different things we use in our practice. These laser and light devices, some of you may be familiar with them. We actually have a really nice set of lasers in derm. So we have our vascular lasers, like our pulse dye, fractional lasers, which can be classified as ablative or non-ablative, picosecond lasers, intense pulse light, and I'll briefly talk about some other modalities we use. So the most commonly used lasers in our practice are the pulse dye laser and fractional devices. These can be ablative or non-ablative. We do know that these can improve not only the color and pigmentation, but also scar thickness. So we know angiogenesis is essential in scar development. It's one of the key steps in actually wound healing, and our pulse dye laser and KTP actually target the proliferation of vessels. The pulse dye laser is the most common laser used to treat vascular structures in a scar, and it's actually targeting the oxyhemoglobin in the small vessels that not only decreases erythema, but also improves cosmetic appearance. One interesting fact, even though we are targeting the redness, studies have shown it also stimulates collagen production if you use subpurpuric settings, so settings where you're not actually bruising or rupturing the vessels, but just enough energy to stimulate collagen. It's also shown to help the scar pliability, thickness, and pruritus. So this is a picture of our V-beam perfecta. It is one of the most commonly used pulse dye lasers on the market, and we have one at our main campus. We also have one in Avon. So another question that comes up is, when is it safe to treat? So this has been studied extensively in the derm literature. And ironically, it's safe to treat at suture removal. So they looked at a split scar study, and they had essentially, one half of the scar was treated with laser, the other half was left alone. And after 3 sessions of the pulse dye laser, there was increased collagen in the half that was treated, and less erythema and improved texture. So the thought of this is you could actually influence how a scar forms rather than letting it form and then trying to rehabilitate it. So, our pulse dye laser, we use it for surgical scars. We use it for acne scars. This is a picture after 2 sessions of pulse dye laser for like the erythema from acne scarring. And then a patient of mine, once again, this was after 2 sessions of the pulse dye laser for acne scarring. So you can see it reduces the redness. It also does help texture. Moving on to fractional lasers, these are the gold standards for improving our textural and structural abnormalities. These rely on bulk heating that, we create thermal injury. There's something called these microscopic thermal zones. And as the name suggests, we treat a fraction of the area. So in the past, fully ablative areas were used where you ablate, 100% of the skin. Now we can actually pick anywhere from 5 to 90% of the skin that we want to treat. These microscopic thermal zones lead to tissue contraction and remodeling, and that forms new collagen. You're essentially using the wound healing response to controlled depth damage the scarred collagen, and then your body will replace it with new collagen. They can be divided into 2 groups. We have our fractional ablative lasers and then our fractional non-ablative. The difference between the two, so ablative lasers, we remove parts of the epidermis and the dermis. They are more effective. This would be like your CO2, your erbium, but they have more downtime and a higher risk of scarring. The one nice thing is it allows for laser-assisted drug delivery. So after you make those channels in the epidermis, you can actually apply things like triamcinolone, polyl-lactic acid, omatoprost to get into the reticular dermis and actually cause some change there. You also get some skin tightening from heating the reticular dermis. This is in contrast to our non-ablative devices. So they treat a fraction of the skin, but they do not break the epidermis. They deliver heat to the dermis only. There's a lower risk of infection, of pigment alteration, and further scarring. It is safe in all skin types. However, they require more treatments, and it is the treatment of choice for our flat atrophic scars. This is a picture of someone Dr. Vitamus treated in our department with fractional ablative CO2. These were keloids from acne. So moving on to, this is probably the newest and kind of one of the hot topic lasers right now, which is our picosecond laser. We're actually very fortunate to have one at main campus and one at our Avon location. These are classified by an ultra short pulse duration. So as the name implies, our pulse dye laser is in milliseconds. This is in picoseconds, so very short bursts of energy. FDA cleared for different things. We use them mostly for pigmented and tattoos. Pigmented lesions like lentiginous and then tattoos, but it can also be used for scars. There's a special handpiece we use that kind of distributes low-level energy to the entire area that can, stimulate this new collagen synthesis and a dermal healing response. This is just showing from the initial studies with this device back in 2014. You can see pre and post. Not only do we have increased collagen, and then the gray in the photo is looking at increased elastic tissue. So this is why we know that it helps with any type of scarring, because we're getting that stimulation of collagen and elastic tissue. This is also used for rejuvenation because it can help with wrinkles. Wrinkling of the skin is caused by a decrease in collagen and loss of these elastic fibers. So stimulating both not only will help scars, but is also rejuvenating as well. This is a picture after 2 sessions of our with the picosecond, our focus lens array. This is a patient like skin type 3 who's Asian. So the nice thing about this device is you can also use it in all skin types. So as I mentioned before, percutaneous drug delivery is something very new that we do in our practice. Essentially, you rely on the channels you create through the epidermis to deliver a medication directly to your dermis. These microscopic channels allow for even tissue distribution, and it's best if done immediately after treatment. So after 30 minutes, you start to get like a fibrin clot, things start to close by 6 hours. So for hypertrophic or keloidal scars, we actually apply triamcinolone or Kenalog afterwards. And then for atrophic scars, we actually apply topical polyl lactic acid, which is Sculptra. So anytime you're trying to stimulate more collagen, you can use polyl lactic acid. When you're trying to reduce the amount of collagen or reduce a thickened scar, you can use triamcinolone or Kenalog. Briefly, I'm going to touch on microneedling. Microneedling has been around for a while. It's been used for many things, as you can see here. I'm just going to focus on its use in scars. So microneedling is also referred to as percutaneous collagen induction therapy. Unlike our lasers that use heat, this actually uses mechanical injury. There are different types of devices. You can see on the picture on the right, we have a stamping device where it's motorized, the needles go in and out of the skin. And then a rolling device. These needles are on a drum. Most of the commercially available devices are motorized. That way you can, there's a disposable tip that you could use for each patient, and they're much quicker to do treatments. With this, the epidermis is actually preserved, and then these little micro injuries release growth factors. So we get, essentially using the wound healing response, new blood vessels, new collagen. And because there's no heat involved, it's safe in all skin types. It's something popular in the summer when patients are tanned. We don't like to do any laser treatments. But when, since this is, heat independent, this can be done on any skin type, any time of the year. So essentially what happens, these needles penetrate the skin, we do damage the superficial collagen bundles, and then we get induction of collagen and elastin through a wound healing response. The platelets release their growth factors, and it goes through the inflammation, proliferation, remodeling phases, and this does continue for 6 months after treatment. We are able to adjust the depth anywhere from like 0.2 millimeters all the way up to 2.5 or 3 millimeters, depending on the device we're using. So we can tailor it based on the scar, based on what area we're working on. The science behind it, this study from several years ago looked at 4 monthly sessions. And they found a 400% increase in collagen and elastin 6 months after the last treatment. So if you recall, like on pathology, when you look at a scar, these collagen bundles kind of have a very distinct appearance in the scar, this parallel pattern. So after doing this, they were more normalized to a lattice pattern. So also looking at histology, this is, baseline, and then showing after 12 weeks of microneedling, you can see the thickened epidermis. These patients were also using a retinoid, vitamin A, and then also an antioxidant, vitamin C. So the difference after several microneedling sessions, you can see histologically too. And then looking at baseline, and then the green is showing the increase in collagen after 12 weeks, using also retinoid and vitamin C. So the procedure is actually very straightforward. All of our procedures are done while our patients are awake, just in an outpatient setting. We do a topical lidocaine for about 20 or 30 minutes. You do need a glide agent to reduce friction. So we have these hyaluronic acid gels. You can use the patient's own blood, like platelet-rich plasma. There are different serums that are meant to be dermally delivered. So these are sterile serums. We do change the depth based on location, and patients feel like a vibrating sensation. And then the endpoint is pinpoint bleeding. I am going to share just this brief video. So this is just, usually a full face microneedling takes around 10 minutes. So you can see I just applied some hyaluronic acid as a glide. And then, the needles here are set to 2.5 millimeters. And then you will see you get some pinpoint bleeding pretty quickly. So these take about probably 3 to 5 days for the patient to heal. And as you can see, very, very comfortable with the topical lidocaine. Patients don't feel much, but they look a little, like a little sunburned after. There is some bleeding or oozing maybe the first 10 or 15 minutes. I'm just going to fast forward here a little bit. So you can see this is what it looks like as we're finishing an area, but when you wipe, they just look sunburned. So each of those needles, there's 12 needles, and essentially they're going in and out of the skin to penetrate the reticular dermis. And that pinpoint bleeding is when we've damaged our superficial collagen bundles and the platelets are delivering their growth factors. So, we do this for rejuvenation, for acne scars, for surgical scars. So it's probably one of our most popular treatments. Okay. These are just some pictures of patients I've treated. So, perioral rhytids, if they're mild, this patient had 2 treatments 4 weeks apart. Striae, this patient had, we treated the erythematous component with the V-beam laser, and then we did microneedling treatments 3 times and overall improved. And then a surgical scar, this was a Mohs patient. This was after 3 sessions. So, it can be used for a variety of things, and it's pretty comfortable and, minimal downtime for the patient. I'm just briefly going to touch on some surgical scar therapies. You all probably do these and know these better than I do, but just for completeness sake, I'm going to touch base on these. So, scar revisions like Z-plasties. For acne scars, sometimes we'll do punch excisions. There's subcision, which will many times combine with our ablative lasers. And then dermabrasion, all of these require local. So this was a picture of a patient that had, pretty deep ice pick scars. And then after punch excisions, much improved. This is a patient, keloidal scar, and then Dr. Vitamus did an excision here. So, we can use these for a variety of things. Intralesional medications, we do a lot of also. All of these target like your fibroblast growth and collagen production. The most common ones we use are Kenalog and 5-fluorouracil. Ironically, the combo of the two are considered first-line therapy for your hypertrophic or keloidal scars. At the clinic, if you want 5-FU, you just have to put an order in, and then the chemo pharmacy can actually bring it to clinic for your patient. I do a lot of these combination treatments with lasers to get the patient, optimal improvement for these thickened scars. I typically do it monthly until it's flat, and then you just want to do small amounts until you get blanching. The nice thing about 5-fluorouracil is that you don't have the risk of dyspigmentation, atrophy, or ulceration like Kenalog does. So usually I do a combination of either half, 1 part 5-FU, 1 part Kenalog, or even 3/4 5-FU and 1/4 part Kenalog. And the studies have shown that the combo of the two is better than ILK alone. Just keep in mind that 5-FU is pregnancy category X, so you want to make sure you check a pregnancy test in your females of childbearing age. Other therapies I'm just briefly going to touch on that we do in our department, not commonly, but we offer photodynamic therapy for some of our resistant keloids. And then we also share some patients with radiation oncology. So, when we have these difficult patients with these large keloids that have been excised, we've lasered them. They're obviously causing functional and cosmetic disfiguration. What do we do with these patients? So, our colleagues in radiation oncology have been great. Many times we'll do like a CO2 excision and then have them radiate the area after. I'm sure you guys are familiar with this when you use it for, when you work with your colleagues for different tumors. But essentially for keloids, these external beam radiation can inhibit the key steps of fibroplasia and angiogenesis in our keloids. So one study looked at, looking at different keloids. Because keloids have such a high recurrence rate, they were looking for adjuvant therapy. They found it works best if it's done immediately after surgery, either the same day or the day after, within 24 hours. And they found the recurrence rate decreased from 94% to 32%. And this was at 2 years. So we know keloids have like a high chance of coming back. So radiating them really decreased the chance of recurrence at the 2-year mark. So they found that after keloids are radiated, the overall recurrence rate was 27%, and there was a low recurrence rate when done after excision compared to just excision alone. So this was a patient of ours who had extensive keloids. This was, believe it or not, due to acne. So she had a CO2 excision. We take it down to fat to try and get rid of all those keloidal cells. And then she was radiated immediately after, over 3 days. This was following her CO2 excision, and then 1-year follow-up. And then we have some photos, excuse me, at the 2-year follow-up, and she continued to do well. She still did have some atrophy and depressed areas, but she was symptomatically, but she was very happy with her decrease in symptoms and just the overall appearance compared to where she started. So another thing we do in our department is photodynamic therapy. This is most often used for precancers or actinic keratoses, but we use it for a lot of off-label uses also. It relies on using a photosensitizer, which is aminolevulinic acid or methylaminolevulinic acid that produces protoporphyrin 9. So protoporphyrin 9 then generates these free radical oxygen species that have a cytotoxic effect. Those go on to basically induce apoptosis of our keloidal fibroblasts. So it's shown to be in scars that we know that over time it decreases blood flow, increases pliability, decreases the collagen levels, and reduces keloid volume. So this is also something to consider that we can do with our thick scars. So this was a patient with, large keloids on the back that were resistant to everything. I mean, when they get to be that size, it's really, really hard to even inject or do much with. So once again, this was a fully ablative CO2 excision. We try and get it down to the base to like healthy adipose tissue, and then had several PDT sessions. This was done with red light PDT, 3 sessions, 4 weeks apart. And you can see even at the 1.5-year follow-up, continued to do well. So we have a lot of options. Every now and then when we get these difficult patients, it's nice to know that we have colleagues in radiation oncology or my colleagues in dermatology who do a lot of PDT. So just in summary, the realm of scar therapeutics is currently changing. It's important to consider many factors when we develop a treatment plan. Combination approach is ideal. And in our practice, we really try and rehabilitate the scar rather than replacing it with a new scar. So, that was a little faster than I thought it would be, but I'd be happy to take any questions. And I thank you all for your attention this morning.
Thank you, Dr. Khetarpal. Do we have any questions?
Good morning. Can you hear me okay?
Yes.
There's incredible background noise. Shilpi, thanks for the great lecture. Appreciate it so much. I think my questions are 2. One is maybe if you have any more insight into your specifics of your experiences with the combination of 5-FU and Kenalog for keloids and hypertrophic scars. We've had a little challenge for our nurses and knowing how to get it in clinic. And so maybe any advice of who they should speak to in your group is question number 1. But number 2 is if you have any experience with early treatment of early laser treatment for incision lines after surgery. I had some experience, I think it was with Tina Ulster in DC when I was in Baltimore, who would occasionally treat some of our patients like 1 week after surgery. And, her group was convinced that it would, and a group of our patients also became therefore convinced that it would ultimately help the long-term outcome. And I don't know if there's much data behind that, but any comments would be appreciated.
Sure. So about your 5-FU Kenalog question, if I can share with you guys or email you the order set. So once a physician puts the order in, you could do it for like every 4 weeks, every 6 weeks. And then your nurses just have to call the chemo pharmacy when the patient arrives and they'll bring it to you. So there's a place in the basement too, in the cryo basement, where they could go and pick it up. So the physician just has to place the order for the 5-FU and then the amount you want, and then the Kenalog, you just mix it, before it's injected. You'll do that part in clinic. It does take a little bit of time, but we've kind of, we just allowed ourselves maybe 5 or 10 extra minutes to get the 5-FU. I would say in my experience, I do this routinely. So on scars on the head and neck, I usually use Kenalog 10 with 5-FU, and then I'll start initially with 1-to-1, so 1 part 5-FU, 1 part Kenalog. If it's a patient that's skin of color or on a very, thin skin area, like they're older and it's on the lateral neck, I'll probably do 3 parts Kenalog or 3 parts 5-FU, 1 part Kenalog. On the body, I use Kenalog 40 and then start with 1-to-1 and then just, until it blanches small aliquots. Do warn patients, it does burn a lot. The 5-FU has a pretty low pH, so it's a little bit uncomfortable. But I'm happy to share just we have kind of a workflow that's worked for us in the clinic, how to get it. So I can share that with you. And then in terms of when to treat scars, I agree with you in terms of treating right away at suture removal. 7 to 10 days is ideal. Sometimes it's hard to get patients in the door, that early, since they're still recovering from their surgery. But the literature does support, treating early as soon as 7 days. And that's not only with our pulse dye laser, but also with CO2 or resurfacing devices. The thought behind that is you can actually influence how a scar forms rather than letting it form and then trying to rehabilitate it. So early treatment is best just so you could influence those key factors, and all the studies show it's safe and it's more effective in terms of, their final outcome.
Thanks. Great talk.
Great. Thank you.
Thanks for the great talk. It's Jake Wells here. Just wanted to clarify, do you ever do the injections immediately after the excision, like day 0?
Yep. So sorry if that wasn't clear. So I would say for the 5FU and Kenalog, generally no, unless you're starting to see a keloid form right away. I don't typically inject them at suture removal. The lasers are safe to do as early as suture removal, but the injections typically when you start to see like thickened tissue or clinically a keloid or a keloid or a hypertrophic scar forming. There's no restriction as to when to do it, but typically those won't form for the first few weeks. So once you start to clinically see that it's thickened, then I would recommend treating with the injections.
Great, thank you.
Thank you.
Shilpi, can you hear me? This is Allison.
Yes. Hi, good morning.
So, good morning. So when we do those CO2 laser keloid excisions and we're allowing it to granulate, we do inject right then. So we'll put Kenalog 40 at the edges of the wound and then repeat it every month. That's if they're not doing radiation. Now, if they've recurred multiple times, we send them right from our table over to Rad-Onc and they get their short course of radiation therapy. But we will, with the second intent healing wounds, inject right away. The worry is if you inject, go ahead.
Oh, no, sorry, go ahead.
The worry is if you inject a sutured wound, it may actually open up, because it can basically weaken the wound a little bit.
Yeah, and even for those large keloids that we do the CO2 excision, you can also topically apply it to the base. So not only injecting around the edges, but also just topically applying Kenalog 40. But once again, yeah, those are the big keloids that we're doing like CO2 excisions for. But I think if you're doing like a standard surgical excision, I agree. I wouldn't inject anything at suture removal. And usually it's going to take weeks for a keloid to form anyway. So.
That one African-American man that you showed the lateral view of, those were not excised and sutured. He had the lamb chop type keloids, and we first took care of the large post occipital keloid, let that granulate after radiation, and then same thing on his jaw lines. We excised, just let it granulate and radiated. So it looked like a sutured wound, but it just kind of pulls in really nicely and stays flat. Thanks for showing those.
Great, thank you. So if anyone has other questions or specifics, please feel free to email me. I'm always happy to see your patients or, to help in any way. But and I'm more than happy, Dr. Burns, I can send you our algorithm and just kind of workflow for the 5FU, and you can share it with your group for those who want to incorporate it in their practice.
That'd be excellent.
Great.
Nicole, did you have your hand up, Nikki?
I did. I was just going to say, do you mind sending me the information for the 5FU? I've been getting kind of the runaround from pharmacy on how to bring that to our floor.
Sure.
Several different workflows they were telling me. So whatever works best for you, I'd like to replicate that.
Absolutely.
Thank you.
I have a question. So are all of these scar treatments considered cosmetics and pocket expense for the patients, or depending on the mechanism of injury and the cause, are they sometimes covered by medical insurance?
Yeah, that's a great question. So in my experience, like the hypertrophic or keloidal scars, insurance will generally cover the injections, like the Kenalog 5FU. In terms of like lasers, things like that, I think a lot of it depends on what it's for. So obviously patients having like, a facelift or, cosmetic surgery, it's going to be an out-of-pocket expense. But I have had it covered when patients have had large tumors removed or it's causing like functional impairment. We can get it covered by insurance, especially if they're like itchy. And a lot of the keloids, when we do lasers for, we can get it covered. So I think it's a case-by-case basis.
So for those cases where you're planning on doing the treatment as suture removal, how does that work? Because you're doing more of a preventative care.
Yeah, that's a good question. The patients I've done that on were almost always our aesthetic patients. So they, they incurred the like out-of-pocket expense. Dr. Burns, I'm not sure, how did you do it previously when in your old practice when these patients were being treated? Was it, was that kind of included as part of the procedure, or did they pay out of pocket for that?
For aesthetic patients, they paid extra for it. Yep, and because we work mostly with Kazin and Ulster's group, it would be a separate charge, not bundled into ours.
Does anybody else have any other questions? A lot of great information.
Great. Well, thank you again for having me, and I appreciate everyone's attention this morning.
Thanks,
Thank you so
Shilpi.
much. We have
Thank you.
time
Thank you,
to talk.
Shilpi. Have a great day.
Great. Thank you.
Have a great day, guys.
Thanks, Jamie.